Good morning, everyone. Thank you so much for joining us today for the first event of the NASW New York City Spring 2023 Senior Series, Meeting the Needs of Families Impacted by Alzheimer's and Other Dementias. This Spring Senior Series is in collaboration with CaringKind, the heart of Alzheimer's caregiving. So just a few items before we begin. My name is Angelique Imani Rodriguez, and I'm the Manager of Community Engagement and Volunteer Initiatives here at the NASW New York City chapter. I coordinate, organize, and facilitate a lot of the free community engagement events like the Senior Series and more here at the chapter. So post-event, an email will be sent to all attendees with how to get involved with NASW.
Recording in progress.
Membership info, and any information from our presenters they have sent my way to share with you. We hope that when registering, you opted to join the NASW New York City email list, which gives you access to all of our updates, news, and upcoming opportunities. So what is coming up at the chapter? Currents, the biannual chapter newsletter has reopened for submissions, and yes, we do accept submissions from students. The deadline for submissions is May 12th, so make sure you submit your work if you're interested. And of course, applications for our student liaison program, the NASW New York City Cares Member Ambassador Program, as well as our NASW New York City Cares Mentors Program reopens for the next round in May. Additionally, registration for the NASW New York City Virtual CE Conference is still open. You can earn up to 9 CE contact hours during our 2-day virtual conference. And if you don't need the CE contact hours, but still want to engage with the conference, the chapter is currently still seeking volunteers to support the event with opportunities to engage with leading social work professionals and get highlighted in our spring-summer issue of Currents. If your organization or school is interested in attending, we also have some sponsorship opportunities as well as discounted group registration rates. Lastly, save the date for the NASW New York City Cares Virtual Social Work Job Fair on July 19th. That's Wednesday, July 19th, 2023, and the Empower Your Practice series being coordinated in collaboration with the co-chairs of the NASW New York City Psychotherapy and Wellness Practitioners Group happening at the start of August. Okay, I know that was a lot of information I just mentioned, but as I mentioned before, all of this information about how you can get involved and engage with the chapter will be included in your post-event email along with everything shared during today's event. Expect that email to be sent later this week, so keep your eyes open for it. If you have any questions regarding community engagement at the NASW New York City chapter, I'll drop my email in the chat for you shortly. Once again, thank you all for joining us today. And without further ado, it is my honor to introduce you to Erica P. Sandoval, and she'll introduce our presenters for today. Erica, whenever you're ready.
Good morning, everyone. It's wonderful to be here today. Thank you for joining us. We have an incredible program today that is going to highlight all the reasons you should have connections to CaringKind. One of the main things that we want to ask is, how can we break barriers to reach communities of color? We know that many of our communities do not have access to resources. So how can we do that? We should definitely connect with mental health and all healthcare professionals, especially of color, in our networks with CaringKind services. And today, you're going to be hearing from many of the CaringKind staff. And CaringKind services are amazing and so culturally competent. And the referral source and the referral line is important to ensure that they understand the communities that we are reaching. We need more memory care providers to be people of color and linguistically diverse, especially in the engagement positions when we are connecting with the communities that may not really be trusting of resources that they don't know of. And we also need to train all memory care providers to be culturally humble. And we have to connect with and earn the trust of not just people of color living with Alzheimer's or dementia, but also the family, the caregivers, by helping break the stigma of getting support, of reaching out for support, of reaching out for apoyo. Mental health care professionals need to lay the groundwork, and also all healthcare professionals and community healthcare professionals, social workers, of people that are trusting with people that are young and middle-aged. So when they trust us, They are able to work with older family members in the near future, and they're able to also pass on the resources to others. Trust is so, so important. So who is providing the information is invaluable. And when communities need Alzheimer's or dementia's care, and they might also have a family member or a person that they know that might need these resources, they're already familiar with this, and they're able to also get this information, order it to their community and their family. We need to continue to break the stigma of mental health care and also healthcare and wellness and access, especially with communities of color, and ensure they have these resources that will support their mental health and wellness needs. I need to create Alzheimer's and dementia care programs and facilities that are culturally humble, expand options for treating and living with Alzheimer's and dementias beyond the Western medicine, and let patients access a treatment that aligns with their culture. We also have to increase cultural familiarity and the environment and surround patients in order to reduce patients' negative experiences. We want to empower people of color that are impacted by Alzheimer's and dementia and their families, because Alzheimer's and dementias are disempowering disease. And because of the cognitive and physical abilities that patients experience, communities of color, disenfranchisement is so much of their lives, and especially medicine, and access is one of the largest barriers. Therefore, effective Alzheimer's dementia treatment should empower these patients and their families with options for care and moving forward, instead of being so prescriptive. Instead of just giving a prescription for something. This is why CaringKind is so important, as they are hitting all the marks and are here to connect with all of you today to reach our communities. It is such an honor to introduce the CaringKind team. Susan, take it away.
Thank you. Thank you, Erica, and thank you everyone for being with us today. Today's presentation is going to talk about how we attempt to meet the needs of families impacted by Alzheimer's disease or a different type of dementia. And we're going to start with a short version of our understanding dementia education, and then two of our social workers, Adina and Dante, will talk more specifically about the programs and the services that we offer to families, caregivers, care partners of somebody who has a diagnosis, or somebody who is taking care of somebody with a diagnosis of dementia or Alzheimer's disease. So first, a little tiny intro to CaringKind. We were founded as the Alzheimer's Society in 1978. So right now we have about 45 years of experience working in New York City. But we actually help people not just in New York City, but all across the US. In 1985, we became the New York City chapter of the Alzheimer's Association. And then when the Alzheimer's Association centralized in 2015, CaringKind decided to remain independent. And so we've been an independent entity helping people living with a dementia and their families and care partners since 2015. Our mission is to create, deliver, promote comprehensive and compassionate care and support for the families that we serve, the individuals that we serve. We have a research branch that stays current on top of any new developments and do advocacy on behalf of people affected. And we achieve our mission by providing programs and services for individuals, family members, professional caregivers, and to increase public awareness about the disease so that we can hopefully one day overcome the stigma that is surrounding this horrible disease. So who is it that we serve? We serve people that are living with Alzheimer's disease or any other type of dementia. We serve their family members, their partners, their friends, and anybody who provides care support to somebody who is living with a dementia. We also provide education to care staff in healthcare settings, aging care settings, and any other dementia service professionals. And we go out into communities, into residential settings, and we provide coaching and education to their staff. Next slide. So what is dementia? So dementia is really an umbrella term for that describes any kind of like long-term chronic changes in thinking abilities that or any kind of deterioration that happens in the brain. It usually refers to changes in memory plus changes in one other cognitive ability, such as forgetfulness, such as language, such as problems handling money or paying bills. It is an umbrella term, just like cancer is an umbrella term for all kinds of different diseases as well. Dementia is brain changes that impacts a person's abilities in their activities of daily living and in their relationships. There are a lot of conditions that affect our memory. So why is it important to get tested? Because some of them are curable. You know, there are a lot of conditions such as depression, such as sleep apnea, such as vitamin B12 deficiency, strokes, brain tumors, inflammation, Lyme disease, UTIs, and medication reactions, many things that affect our cognition, and some of those are very treatable, curable, healable. So that is the reason why it's important to get tested. There are a lot of things that can affect our memories, and people are fearful of getting tested because of the stigma, and that fear could potentially keep people from reversing these treatable conditions. One of our early stage clients once said, I don't run as fast as I used to, and I don't jump like I used to. So why do you think that I would be able to remember things like the way I used to? So while this is true, a significant change in abilities indicates that something is wrong, that it could be treatable. And just like we get our cholesterol tested, we get our blood sugar tested, our cognition should also be tested so that we can create a baseline for what is our new normal. For instance, if you were always bad at math, we want to have that documented. If you were somebody who weren't good at spelling, we want to have that documented so we don't make the mistake of thinking that there's necessarily something wrong with our memories. So what are some of the things that could be warning signs? Here are 10 highlights of warning signs. It doesn't cover everything, but those are the most common ones. Memory loss, specifically short-term memory loss, difficulty performing familiar tasks, problems with language and word finding, getting lost in time or place, going to a familiar place and all of a sudden not remembering where you are or where you were going, changes in judgment, in organization, in planning, mood changes and withdrawing from social activities, and little mishaps such as could turn into big mishaps, fender benders, and misjudging spaces and visual information, because that is also something that happens when that could happen when there's a cognitive decline. And if you experience them from yourself or if you see them in others, it's important to get it checked out to see if it may be one of those treatable conditions that was in the slide from before. Some statistics, I'm not going to spend too much time on that, but currently dementia is the 7th leading cause of death worldwide. It is one of the major causes of disability and dependency amongst older people, and it has physical, psychological, social, and economic impacts, not just for people living with a dementia, but also for their caregivers, for their families, and for society at large. Alzheimer's disease, like we talked about that umbrella term before, but Alzheimer's disease is the most common cause of dementia. making up about 60 to 80% of all dementias. In 2022, over 6.5 million people are affected by Alzheimer's disease. By 2050, we expect that it's going to be more than 14 million as the populations age. About 1 in 9 adults over 65 will have a diagnosis of Alzheimer's disease, and the risk increases with age. 1 in 3 older adults will die from Alzheimer's disease, and currently it is the 5th leading cause of death in the US. In New York specifically, we know that in 2020, there were 410,000 people diagnosed with Alzheimer's disease, and that's going to increase to 460,000 people by 2025. We have 586,000 people that identify as caregivers. And those caregivers are providing 774 million hours of unpaid care to the people that they are caring for. So basically, what are the risk factors? If you have a brain, you're at risk. Some of these risks are not modifiable. Age, the aging population, your family history, and your genetic makeup. Some are modifiable. We know that even though scientists haven't really figured out why some people get a dementia and others don't, we know that there are a lot of things we can do to help prevent a dementia, and it's very much lifestyle. So exercise, a healthy diet. Right now, researchers believe that the Mediterranean diet is the healthiest diet. Not smoking, limiting alcohol, and recently a research study just came out a few weeks ago that dental hygiene is also really important to decrease inflammation, to prevent, inflammation in the gums. So what is good for your heart is good for your head, is good to prevent dementia. So treat high blood pressure, treat cholesterol, treat diabetes, keep your BMI under 30. And then psychosocially, stay engaged, stay active, see your friends, challenge your brain, learn new things. Cognitive stimulation is really a huge piece of the puzzle. Cognitive stimulation and brain games are showing more and more promise to help your brain stay healthy and to open new neuron pathways in the brain. So stuff like Sudoku and crossword puzzles are actually really, really good for your brain. So what is Alzheimer's disease? We all hear about these plaques and tangles. So plaques are built up in between the nerve cells. In Alzheimer's disease, the plaques contain deposits of a protein called a beta amyloid. In Lewy body dementia, the plaques are made up of a different protein. Tangles are twisted fibers of another protein called tau. Tangles form inside dying cells, and though most people develop some plaques and tangles as they age, those with Alzheimer's and other dementias, they develop far more. The plaques and tangles tend to form in predictable patterns, beginning in areas important in learning and memory, and then spreading to other regions. Scientists are not 100% sure what role plaques and tangles play in Alzheimer's disease, but most experts believe they somehow block communication between nerve cells and disrupt activities that cells need to survive. Different areas of the brain control different functions, and yet there's a lot of overlap in large skills like communication, which is more than just language. So for instance, if I said to you, go to the bathroom and brush your teeth, that command requires information to be communicated to at least 4 different parts of the brain. In the parietal lobe, you'd think, she's talking to me and she wants me to do something. Then the command is transferred to the temporal lobe, to the long-term memory of procedures. Do I know what it is that she wants me to do? Brushing my teeth? Yes. Making a souffle? No. Then the command goes back to the cerebellum to physically walk to the bathroom. And once in the bathroom, the information goes all the way to the frontal lobe for tools, identifying and sequencing in order to perform the task correctly. So it really does affect many different areas of the brain. So what are some of the changes that we see when somebody is diagnosed with Alzheimer's disease or, a different type of dementia? We see changes in memory, changes in executive function, changes in visual spatial function, changes in language, processing information, muscle movement, and sensory functions. Clinicians often define dementia based on the criteria given in the DSM-5. And the criteria for dementia is the following. Symptoms must include a decline in memory and at least one other cognitive domain, such as complex attention, executive function, learning, language, perceptual, motor, or social cognition. The client must also be experiencing steadily progressive, gradual decline in cognition. The decline in cognitive abilities must be severe enough to interfere with the activities of daily living. Symptoms must not be due to a delirium, such as a sudden onset, short-term cognitive changes due to an infection. Very often we see that in the older population where a lot of people get urinary tract infections that can cause a change in mental status. And it must not be better explained by another mental disorder like a major depression or schizophrenia. And here are some of the stages that we are currently working with. And of course, the early stage kind of depends on when somebody is receiving a diagnosis, because when people are living their lives and staying in their regular routines and going through their daily lives and their structure, we don't always notice that something is amiss for a long, long time. So we talk about three different stages: the early, the middle, and the late stage. And the two first stages, they last about 2 to 7 years, depending on the type of dementia, and the late stage 1 to 3 years. But the stages of specifically vascular dementia and frontal temporal dementia will be different. They progress a little bit faster than Alzheimer's disease, for instance. But we need to remember that even when somebody receives a diagnosis, they have many, many years left to live well and to live with purpose. All dementias are chronic, progressive, and fatal, no cure. And right now we have limited medications to help with the symptoms and only 2 known treatments that will slow the progression. One way to determine stages is for somebody trained in dementia care, occupational therapy, for instance, or other clinical areas to observe and test using a variety of different tools. Right now, we can use the Global Deterioration Scale, which was developed by Barry Reisberg. We can do cognitive rating scales and tests such as the MOCA or the SLUMS. We can use the functional assessment test, the FAST, and there are some other staging scales that was developed by Claudia Allen, who was also an occupational therapist. So what are some of the things that happens with executive function changes? Sometimes the early clues of brain change can be picked up due to the damage in the front of the brain, higher order thinking. So that can be difficulty organizing, difficulty in planning and initiation, the inability to perform multiple tasks, difficulty with verbal fluency, trouble making plans for the future, difficulty processing, storing, or retrieving information, mood swings, lack of concern for people and animals, pets, loss of interest in activities, socially inappropriate behavior, inability to learn from consequences from past actions, difficulty with abstract concepts, for instance, the inability to make the leap from the symbolic to the real world, and unawareness or denial that somebody's behavior or that your behavior is a problem. We also see changes in the visual spatial area, in processing speed and reaction time, in coordination, in taste, smell, sensation, and in balance and physical activities. So this is Richard Taylor. He was one of the first advocates in the US to speak out as an advocate living with the disease. And he does not want to be defined as a disease. He is saying he is not dying from a disease, he's living with a chronic cognitive disability. He has written a book called Alzheimer's from the Inside Out, and he has a lot of inspiring talks that you can watch just by Googling his name. He is also very deliberate in referring to himself as a person living with the symptoms and diagnosis of dementia, sorry, probably of the Alzheimer's type. He asks, what makes you you? What makes me me? He wants to be recognized as the person he is. So if I was to ask you, how do you describe yourself? Or how would your friends describe you? What would they say? Would you say, hey, I'm the hypothyroid? Or hey, I'm the total knee replacement? Or I'm the diabetic? No, that's not how we talk about people who have a diagnosis of dementia or another cognitive impairment. So we don't want to think about our diseases as something that define us. What makes me me? We want to think about the person that I am, the aspects of my mind, the abilities of my body, the experiences of my senses. But we are more than these things. There's more to us, call it being or soul or spirit. And we need to remember this reality when we engage with people that are living with a cognitive impairment. Here are some age-related changes that happen with memory and learning. It is common to have increased difficulty finding words. It is common to have problems in multitasking. And it is common to have mild decreases in the ability to pay attention, but still ability to learn new things, to create new memories, and to improve vocabulary and language skills. We also need to emphasize that dementia is not part of normal aging. As we age, we will slow down, but I want to stress again, it is still possible to learn new things, and actually learning new things is one of the ways to keep our brains healthy. Try to learn a new language, try to learn to play a musical interest, engage your brain in activities and exercise just like we do. We know that we need to do with our bodies. So that was a little bit about a very, very short version of understanding dementia, which is normally a two-hour educational program. So we're going to jump right into, and Dante is going to join us now, one of our social workers, right into the programs that we have for people that are caregivers, care partners, family members of somebody who has a diagnosis. So Dante, take it away.
Hi, good morning, everybody. My name is Dante Tipiani. Thank you, Susanne. Before I talk to you about the caregiver support programs, I just want to encourage everybody to ask questions in the chat so we can have a conversation as we at the end. But over the weekend, I participated in a conference for geriatric doctors, and a big question was, who is CaringKind? What do we do? They talked a lot about what they do to patients when they have dementia, pretty much the like the medicine type, pharmacological part of their job. But what we do, we complement that. So as I talk and as you hear our presentations, I want you to keep in mind, how can you complement what you're doing to the people that you're seeing? How can we help? Keep in mind, all of the services that we provide are free of charge. We have a complimentary service, including seminars, workshops, one-to-one coaching using an evidence-based intervention program. It's called REACH. I'm going to talk more about that. But before I dive into these programs, I would like to describe who caregivers are, their needs and challenges, just so you can get a better idea of when you see somebody, keep this in mind, what's going on, what they need, and what are some of the challenges that they bring up. And then you say, well, hey, CaringKind can help you complement this. And I'm just gonna touch on the tip of the iceberg here. Next slide, Susanne. Susanne, when I first started, okay, Susanne. Okay, no, different slide. I'm sorry. No, go back. Right there, yes. So when I first started being a social worker, and I'm talking about more than 20 years ago, I came across this quote, really stuck to me. At that time, I was working in pain medicine and working in hospice in hospitals, but this really stuck. And this gave me like a talking about caregivers. It was like, at that point, I was like, what is a caregiver? So our former First Lady, I think she said it best. There are only 4 kinds of people in the world in regards to caregivers. Those who have been caregivers, those who currently are caregivers, those who will be caregivers, those who will need caregivers. That really stuck to me and gave me like the foundation to build, because when we talk about caregivers, we're not only talking about those caregivers who are caring for someone with dementia, because there are a range of others in the oncology world, for example, or in the pediatric world. Next slide, Susan. So a caregiver is a person who needs care, okay? So people who need care, helping, taking care of someone else. The care recipient can be a variety, like I was saying, it could be a child, it could be the elderly, it could be people who have chronic illnesses or are disabled. Caregivers may be health professionals, family members, friends, social workers, or even members of the clergy. Caregiver support programs that we offer are specifically aimed for care partners, friends, relatives of a person with any type of dementia. Next slide, Susanne. The profile of a typical care partner may not surprise you. According to NIH, a caregiver is a middle-aged or older female, a child or spouse of a person with dementia. In the US, at least 60% of unpaid caregivers are spouses, wives, more specifically wives, daughters, granddaughters, daughters-in-laws, and sisters or aunts, other female relatives. Males, I would like to say, are becoming more frequent. And I, as a male, 10 years ago, started as a caregiver myself for my dad. And the roles have changed a lot. So I'm talking to you about the caregiver programs, both personally and professionally as well. Next slide, Susanne. So considering the emotional, the biopsychosocial perspective and changes in role. Family caregivers their needs change over time. The model that I'm going to talk to you about in a few minutes focuses more on family caregivers that help understand their needs and changes over time. Next, Susanne. First, I'm going to talk to you about the need to be self-aware to develop certain how-to skills, the need to learn alone. In the beginning, for some, they absorb this information of having someone in their family with a dementia. They're absorbing this, they're absorbing that they need to learn more information. Next slide, Susanne. The second role, the life of the care partner changes. The need to maintain one's role as long as possible. Like Susanne talked about in the stages, we have the middle, the early, the middle, and the later. And the needs of each stage changes over time. Next slide, Susanne. Third, the care partners support group and social networks come to mind. The need for family support or to explore other supportive services like the ones I'm going to talk to you about. At this stage, there's like, okay, we need more, whether it's family support, we need a support group, we need a social network. That is also part of being a caregiver. Next slide, Susanne. The need for intervention, and this is something very important because if, for example, the social network doesn't exist, then what other interventions are there? Like, for example, the REACH intervention that I'm going to talk to you about, or the NYUCI, which is a counseling intervention, or one-to-one, or therapy, or support group. So there's different types of interventions that we can do, and as well as you in your practices. Next slide, Susanne. Lastly, resources. Resources. As the disease progresses, so does the relevant resources specifically aimed at information, education, training, and support. Next slide, Susanne. Challenges. I could talk to you all day about the different challenges that exist, and they vary. Some at the early, middle, and later stage. In the beginning, some care partners don't accept the diagnosis. Sometimes the person with dementia doesn't accept the diagnosis. There comes a point where respite is needed to give the family member or the care partner a break from their 36-hour day. 36-hour day, they just need a time, a break. That could be in the forms of home care. That could be in the forms of complementary hours in addition to their home care. That could be respite in a nursing home. For example, I once had a daughter who traveled and she lived with her mom who had dementia. And so she had to travel. So there's respite in facilities so that the primary caregiver can do what they need to do. Behavior, personality, and memory changes, I feel, should be number one. I'm talking to you based on like both personal and professional, but behavior is like one of the biggest challenge when there are problems with verbal agitation or physical agitation. Verbal, we're talking about like cursing, pacing. Physical agitations, biting, spitting, pulling hairs. Those are very, very big challenges that can be addressed in different ways. One can be through their doctors to add medication. Another could be through interventions, skill building, learning, And the last challenge is, well, no, I'm sorry, the next challenge is personal care. So as their personal care grows, specifically from the moderate to severe stage, they need more help with ADLs. Some have care at home, but this can be a big challenge with helping, dressing, bathing, feeding. The last challenge that is here are long-term care. And this goes back in the beginning where ideally advanced care planning should take place, where the person who has dementia ideally should express wishes, ideally in the real world, but it oftentimes doesn't happen that way. Deciding what to do, where the person can live, where there's a point where home may not be an option, and also respecting the person's wishes, whether they want to die at home, for example, or in a facility. Next slide, Susanne. So I'm going to circle back here to the first slide about the programs and services that we offer. First, we have Understanding Dementia. These monthly workshops or seminars, seminars are specifically focused for family members. We have other Understanding Dementia for professions, legal, financial issues, Understanding Medicaid. These two are specifically hosted by elder law attorneys. And these seminars, I think, are very, very important to understand how Medicaid works. And we receive a lot of calls saying, well, we have high income, we don't meet the Medicaid eligibility. The attorneys go in depth about full trust, about spend down, etc. And it's a good starting place as the condition progresses. We have monthly educational seminars. These are also well attended, and I encourage you to take a look at them. Every month we have different topics. Some of the most well attended seminars have been caregiving and anger, bathing without a battle. In May, we're gonna have a seminar, what to do when a person with dementia wanders. Next slide, Susanne. Partnering together is one of the workshops, ideally for new care partners. This workshop is specifically aimed at spouses or partners. It's a 10-week, 90-minute educational workshop. I would say educational and supportive as well, with topics like what is dementia? So ideally, when someone is newly diagnosed with a dementia, be in a supportive group and learn what the dementia is. Like Susanne explained, the umbrella term for dementia and the different types of dementia. I'm never surprised how some people are not sure what dementia is. Well, my dad has Alzheimer's. No, but he does not have dementia. And oftentimes there's like that misunderstanding of information. I often get questions about like, well, it's not appropriate for me at this time because it's the normal process of aging. But these groups really are for people who want to learn more, be in a group setting, a supportive group setting. They tell their story. Each session over the 10-week, we do a mindfulness exercise just to kind of relax the person. The beginning of the workshop and at the end, and we have different topics of discussion that range from relationship, grief and loss, stress and self-care, which is so important, the stress and how to take care of yourself, the family member, the care partner, how to best take care of themselves, and access also supportive services, getting help. again, into the legal, the financial, and my passion, end of life issues, advanced directives, preferences, expectations for care. Next slide, Susanne. I mentioned REACH, and some people may be familiar with this type of program. REACH stands for Resources for Enhancing Alzheimer's Caregiver Health. There are different types of REACH interventions out there. There's REACH 1, REACH 2, REACH Out, REACH VA. We adapted REACH Texas, and it provides an assessment, education, training, referrals. We problem solve strategies and support around 9 specific topics. These topics are home safety, using social supports, managing stress. And this is 1-to-1 versus the workshop, which is a group setting. Pleasant things to do as a care partner, and pleasant things to do with the person with dementia. Healthy living, understanding your feelings, skillful communication, decreasing questions, increasing comments, for example, relating to memory problems, behavior, understanding the behavior. Maybe medication is not the best, but you could alter your behavior as a family member. Legal, medical information, and resources. So our CaringKind staff gets trained, gets certified to deliver this type of intervention. We deliver the intervention over a 6-month course, and it's either in English or in Spanish. And it can be at our office, which is at 360 Lexington Avenue in Manhattan. It could be on Zoom, or it could be over the phone. In the beginning of the program, we have a risk assessment measure. We call it RAM, risk assessment measure, which determines the number of visits, ideally, that the person should have within the 6 months. Maybe they would meet every month, maybe more, maybe less. And we focus on what they say, what the care partner brings to the table, and we rate risk for institutional placement of the person living with dementia, and we focus on those highlighted risks that they bring. Everybody who participates in this program receives a caregiver notebook, which has all of these services. We have, again, these different topics, problem solving. The staff encourages, it validates, it empowers the person on targeted topics, connecting participants to support group, to community resources, engagement. Everybody has a family profile to prioritize and address the highest risk. Next slide, Susanne. So this is an example of the notebook and the areas that we cover. The notebooks have pockets where we put additional information. So for example, if someone is looking into more resources about managing stress, we would include that resource in the folder, in their pocket folder of each section. Same thing for skillful communication and resources. Next slide, Susanne. Last week, I talked to someone, and this quote really stuck. And I'm just going to read it. All is not going well, this daughter told me. In fact, I'm not quite sure how to survive every day. I am now taking care of 2 parents, which is even the most challenging, while trying to take care of myself and all of the finances and everything else. And she said, I am interested in this program because she's experiencing a lot of challenges. Next slide. Susanne. So when you think about you're a potential person who can benefit from this coaching program, the ideal candidate for this to keep in mind are the following. The person should actively be seeking help and motivated to learn. Because you may have people who, yes, I want to learn, I want to receive resources and first, but they don't act on it. So they need to demonstrate the signs of readiness to learn and adapt strategies. Not everybody is there. Have a basic understanding about dementia, struggling, and this is the big one, struggling with distressing behaviors with the person with dementia, experiencing emotional challenges and exceptional challenges. So we have unique cases also with people on the younger onset of Alzheimer's, someone who's diagnosed in their 50s, for example, or have frontotemporal dementia. The needs change. The needs for the family members, the stress management techniques, the basics, ABC, a thought record. So within the 6 months, we encourage care partners to record their thoughts, to document what they're feeling, their emotions. Like I said before, this may not be for everybody, and this is something that may not be appropriate. So we have the initial consultation. The person may benefit from case management or from other dementia education. Well, I want to thank you all for listening. Again, encourage you to chat, and I'm gonna pass the floor on to Adina.
Thank you, Dante.
There's some questions in the chat.
Okay.
Would you like to talk about the questions at the end, Susanne? Or
Are the questions specifically pertaining to the partnering together or the let's see. I think we'll do a Q&A at the end.
Okay.
I think that makes
Sounds good.
more sense. Yeah. Hold on. Here we go. So Adina is another one of our social workers, and she's going to talk about, the experience of being a caregiver.
Hi, everyone. In terms of the caregivers, I mean, Dante has definitely touched on a lot of these. But as we know, caregivers face significant physical, financial, and mental health concerns. Dementia is a disease that requires a lot of personal care, and that can also impact the caregivers' physical health, because they might be needing to provide physical support for somebody, either maybe when they're transferring or if they need help with mobility. Financial, home care is incredibly expensive. I also have found several of my clients who maybe have found that since their parent or spouse was diagnosed, that there have been a lot of financial issues that they did not take care of, and then they have to take care of these issues on top of taking care of that person. And obviously all of this stress can lead to a lot of mental health concerns, which I will talk about a little bit further. Family strain and difficult feelings, all of these things are pretty much connected. Okay, next slide. Caregiver burnout. That's pretty much the I guess umbrella term for what we often see with caregivers who have just really reached their limit. A lot of times the signs of caregiver burnout are things like isolation and withdrawal. People are not, I mean, maybe they can't go out, but a lot of times, even if they could, they really don't want to. Loss of interest in things that they enjoy, symptoms of depression and irritability, physical exhaustion. A lot of times they might get sick a lot. Changes in eating and sleeping patterns, overeating, undereating, oversleeping, not sleeping enough. And, if it gets even left even further, it can lead to suicidal ideation. Next slide. This is a great resource for your clients. This is online, and it's a self-assessment for caregivers about burnout. And you can score it, and it asks things like, how a person feels completely overwhelmed, if they're having trouble sleeping, if they're crying, any their physical complaints, all of those parameters of burnout are things that this touches on. It gives a scale, and the idea being, not that it's, I mean, it's similar to like, something like the PHQ-9, PHQ-9, where it's sort of like, it's sort of a assessment so that that you need help. This is showing, oh wow, yeah, you're scoring pretty high. Maybe you should reach out, talk to somebody, call CaringKind, and get some support. Okay, next slide. So one of the major changes that we see with dementia, with any illness, but certainly with dementia, the family system changes. One of the biggest impacts of a dementia diagnosis is role reversal. And we see this a lot with adult children. We also do see this with spouses, where you might have, with adult children, you'll have children who feel like they're taking on a more parental role for their parents. With spouses, you might have one spouse that took care of the finances, and now they can no longer do it, so the other spouse does, which can lead to some issues for some people. When it comes to a lot of what happens, and we see this a lot with siblings, there's a lot of tension around siblings, and what ends up happening is when a parent gets ill, and particularly with dementia, the siblings will start to revert back to their original roles in the family of origin, like when they were kids. So the kid who was the scapegoat will now be the scapegoat. The kid who was the golden child will be the golden child. The super responsible one will be the super responsible one. And it's almost like kind of go back in time with that. And that often can lead to a lot of conflict. A lot of concerns regarding the legal, financial, and medical systems. I mean, that's kind of across the board. A lot of times you also see this with families where there are differences in identifying the problem. One spouse will, or one family member could be a spouse. A lot of times you do see this with spouses where, spouses will cover for each other, and they're not going to want to let on that there's something wrong. And so, the children might see that there's a really big problem with one of the parents in terms of their cognition, and the other parent doesn't want to come to terms with it and doesn't want to acknowledge it, even if they themselves are burning out because of all of the care that the other spouse needs. But also you do see it with siblings where, you'll have the classic cases that I see are where you'll have the caregiving sibling who's seeing the problem right in front of their face. And then they'll have a sibling who maybe comes from out of state, stays for 2 weeks, mom or dad has it together, and they'll be like, I don't know what you're talking about. They don't have dementia. You're crazy. And then there could be a lot of conflict just around whether, the agreeing whether or not there actually is a problem with a parent's cognition. And then there are also trauma and legacy burdens. Just because dementia happens to someone doesn't mean that everything else stops. Any other psychosocial issue. So if there is a history of trauma, that's going to impact certainly the person and the family unit. And these are all things that we can't necessarily divorce from the situation. So these are our things. And I think it definitely speaks to when we're talking about, communities of color, it's certainly something to think about in terms of the impact of racism and of other, marginal issues that happen that doesn't go away just because somebody has dementia. It actually often can compound it. So just also something to think about. Next slide. So I'm going to sort of focus on each family, each relationship. One of the biggest things, and this is sort of similar to what I was saying before, in the sense that, dementia doesn't happen in a vacuum, you have to keep in mind the relationship to the care recipient. So if there was a good relationship to the care recipient, that's going to impact how the caregiving experience looks. If there was a bad relationship to the care recipient, that's also going to impact how it looks. So, we don't want to necessarily just think like if somebody has dementia, all is equal when it comes to what's going on in the relationship. When it comes to spouses, it's not an unusual situation where the well spouse or the spouse with dementia are going to pull away emotionally. Sometimes it actually, before a person's diagnosed, there might be some pulling away just because of the symptoms of dementia. The couple is not aware of it, and they end up getting divorced only for a few years later to find out that the person has dementia. But it's, even if not, it definitely does have an impact on the relationship. Even if they don't necessarily have that sort of dynamic of pulling away, the well spouse is going to deal with issues around stigma, anticipatory loss, and role change, particularly stigma. I mean, I have a lot of spouses who will talk about how they don't want to tell their friends, or they're afraid to tell their friends. I have spouses who, and people with dementia also, who will say, like, once they have come out about their diagnosis, then suddenly all their friends start trailing away. So the stigma is real. Anticipatory loss, a lot of spouses, especially, well, I think throughout the course, but you definitely see it most acutely. I think when a person is first diagnosed, is like, well, what's going to happen? How do you know, how bad is this going to get? When is all of this stuff going to happen? Are they going to not remember me? And they're already anticipating the losses that will be occurring. And I already spoke about role change. One of the big issues that you might see with spouses with dementia is apathy, and apathy happens as a result of the disease. Actually, it can happen as a result of the disease. It can also happen because of depression, but more often than not, it is part of the disease, and that can be very difficult because it's almost like they can't get up and go and do and know what to do, and it's a lot of things do fall on the spouse just to get the spouse with dementia engaged. Another issue that is not often talked about, but is an issue that I think is getting more coverage, are intimacy issues, in terms of how you know, an intimate relationship is going to be navigated, should be navigated. Sometimes a person with dementia might get hypersexual or have some sort of a sexually acting out situation because of the disease, and that also will impact the spouse. So these are all things that should, at least I think social workers should be aware of, that do impact or can impact spouses, care partner, a care partner spouse who's dealing with dementia. In terms of how to help, I think it's really important for family members, in this case spouses, to really have a clear understanding of the illness and its trajectory. I think what was great with the Understanding Dementia presentation is, yes, there is a decline, but you still have many years where you can, live in a meaningful and purposeful way. Just because a person has dementia doesn't mean that, they're gone completely. So, it's important to know, for people to know about what the stages are, what to expect. Another thing that I do tell spouses, though, is even with knowing all of that stuff, there's a very famous phrase in the aging world where if you see one person with dementia, you see one person with dementia. So, just because it's something happened to one person doesn't mean it's going to happen to another person. It's very variable, but it is important to be informed, as I mentioned, dealing with intimacy issues, dealing with communication, Dante mentioned, we talk about that in the REACH notebook and in the REACH program, but learning how to communicate with somebody with dementia. Language is a major component of change with dementia. A person may not be able to understand things as well. They may not be able to communicate as well. And it's important for the well spouse and other family members to learn how to communicate with a person with dementia. And that actually will help with reducing agitation and with just keeping the person comfortable. The other thing, the well spouse should be encouraged to accept help, can be a big one, and reevaluate. And they're going to eventually have to reevaluate their identity, and they're going to use what's called a both and approach, which I'll get to in a couple of slides. Next slide. So when it comes to adult children, again, we have role reversal. I mentioned the sibling issues. The sandwich generation is another very big one, where you'll have the caregiver, the caregiving child will probably have other children, their own children that they have to take care of on top of aging parents. Sometimes I have cases where the caregiving child has grandchildren that they're taking care of and their parent. So there's a lot of competing priorities and who do you serve first and all this other stuff that has to be teased out when it comes to adult children caregivers. In terms of helping, psychoeducation, as I mentioned before, is really essential. I find also with caregivers in general, a lot of times with children, they might say, oh, they're doing this on purpose. My mom is acting this way on purpose. She knows what she's doing. And it may look like she's manipulating, but what I find is, when you explain what's going on in the brain, you show them the plaques and tangles, it starts becoming clear that no, there are parts of the brain that aren't really working, and the brain is not always online. And I think it does help for many people to, once they get an understanding of that, to come to an acceptance of, okay, so I'm going to need to change because there are just parts of the brain that aren't there anymore. So what has been found is that clear communication, finding meaning, utilizing social supports, enhance resilience in families, which I think, Dante, you already touched on. So next slide. So ambiguous loss, and I think this is one of the, what I find with my clients is, once I talk about this, it's almost like a light bulb comes up, lights up, and they're just amazed because it really just describes their experience. So ambiguous loss was a term coined by Pauline Boss. In the 70s, she did work with MIAs, for families of MIAs from Vietnam, where they were dealing with, this ambiguous loss because you had these, soldiers missing in action. You don't know if they're dead or alive. And the family had to sort of deal with, how do we go on with this reality where we don't know if our loved one is dead or not? So what she found in subsequent research is a lot of the same dynamics that she found in those families happen in families of people with Alzheimer's, where it's a little bit different. The person's physically there, but, in terms of their psychological, emotional, whatever, I don't want to say they're not there, because they are, but they're different and they are experienced differently by their families. And there are feelings of loss that get evoked from that. So there's sort of this ambiguity, because it's like the family members are feeling this grief and feeling this loss because the person's there, but the person who they've always experienced is not there. Next slide, please. So in terms of helping them deal with that, it's really important for them to realize that this ambiguity is a challenge. It's a challenge that they're going to have to deal with, because this is the reality. And how do we live with this ambiguity? And this is where that both and thinking comes in. And it's interesting because there's been a lot of research lately, or a lot of hype, I would say, about using improv techniques with dementia. And among many improv techniques, I am in no way an expert, but is using sort of like a but and kind of situation where, somebody just throws something at you and then you just add something else in there. And it's sort of the same idea. So a person is, a caregiver, to use both and is sort of trying to get to a point where they can come to an acceptance of the person is both gone, but still here. It even comes in terms to, it's even helpful in terms of helping the person relate to themselves as a caregiver. A lot of times you'll have, well, I'm a spouse, and so I have to do everything. And, I vowed to, be there, in sickness and health and all this other stuff. And so, I can't take care of myself. I have to take care of this other person. And using both and is sort of being able to say, I'm a spouse and a caregiver. And being able to say I'm a caregiver might be able to give them that space where it's a role, but it's not the only role. I can take care of both the person and myself. So you're really trying to have them be able to put, feet in two different worlds. Next slide. So other techniques or things to think about when it comes to helping caregivers cope. Validation. I think validation is the most important thing. A lot of times our caregivers are in such invalidating environments, or they have to deal with such invalidating systems. And just being able to be heard for so many of them is super, super important. Even if there's not really much that you can do, because I mean, when you're working with people when they have an incurable illness, there is not a lot we can do to cure, but we can be there, we can witness, and that's really very powerful for people. So we really want to be there. We want to validate their emotions. If they're angry, we can validate that, obviously, you know, assuming that they're not acting out in their anger. But just validating it, normalizing it. I mean, you know, anger and guilt are probably the most common emotions that happen in the caregiving experience. What I have also found is telling a caregiver not to feel guilty doesn't work. So what I'll often say is, I'd love to tell you not to feel guilty. I know you're still going to feel guilty, but you should know you're doing everything possible. Another thing to keep in mind and to coach our caregivers is to remind them that emotions change. You know, you could feel a certain sense of accomplishment around caregiving, like, oh, it was a great day today or whatever. And then at the same time, you can start feeling resentful, like, why did this have to, you know, why me? Why am I the one why am I the only one doing it? And, you know, emotions are not static. So also just realizing, okay, so you have a negative emotion, you know, you can get through it and you'll feel something different eventually. Anger management techniques, deep breathing, pausing. I will tell caregivers, if it's really getting so bad, just leave the room, go to the bathroom for 2 minutes. You know, if you just need that space, you know, that's okay. You want to help them identify what's going on behind their anger, and assist them in problem solving. Support groups are really helpful. As I mentioned, about helping the caregiver experience that both and lastly, and I think really, really importantly, is respite. I mean, respite can be, you know, full on home care where the person's getting that you know, the help that they need. It could also be short term. Usually in our situation, we call it respite, a more short-term situation. But in general, getting help is really important, and realizing it can't just be on one person to do everything for that person. Next slide, please. So other resources in that vein, it's really important to know what resources are out there, because there are a lot. The local areas on aging all have caregiver support programs. It's like one of the best kept secrets for some reason. So, and those are programs that are supposed to be given, hold on one moment. Those are programs that are, they're mandated to be giving respite care, which means like a short-term, either short-term home care or short-term, you know, social adult day program or something. They are supposed to be providing counseling. They're supposed to be providing support groups. You know, they may vary by district what they do, but those are like the basic bare bones stuff. So the local area on aging, the local office on aging is a very useful resource, as is the Department of Health, which also has programs to help people with dementia. Programs like CaringKind, Alzheimer's Association, there are a lot of Alzheimer's specific organizations. They all do great things, and we all have a little bit of a different take on what we do. So those are good things. And I would also mention, I didn't think to put this on the slide, there are also other types of dementia specific organizations, like for FTD or Lewy body. Those are also really useful. Parkinson's. So those are also very useful resources. Home care is really important. I like to tell my clients that you want to try to do home care early, you know, earlier rather than later, even if it means like getting somebody in for 4 hours a day just to do laundry or to do the dishes or something, just to get somebody used to having somebody in the home. Because it's very, very hard when you have somebody, they have a major setback, and then they have to go home with 24-hour care when they're used to being alone and having nobody. So you really, if the more we can try to get them used to it, I think the easier it is to have that transition. And I mentioned also adult day programs, which are also really wonderful. They are for, I guess, more of a middle stage kind of situation, but they are these standalone programs. They are dementia specific programs that help. And what's wonderful about them is that they provide what's called a no-fail environment. When you're working with people with dementia, it's not about product, it's about process. So it's all about just doing stuff. So it'll be a lot of music, movement, creativity, art. So those are really wonderful programs. Next slide. We also want to encourage our clients in self-care. I find I tend to balk at self-care or telling my clients about self-care, because a lot of times what I find when we talk about self-care, people think it means like either putting a lot of money into going to a spa or getting your nails done, or time, and so we want to really try to think about self-care in a different way. And self-care is an activity that we can take to better our physical and mental health. So, and there are many components to health, to self-care. So physical, emotional, psychological, spiritual, we don't think about it, but financial, environmental, and professional. And I see I don't really have that much more time, so I'm not going to go through all of them. I do want to mention a few things in terms of self-care, particularly around the financial and professional. Dante, as Dante pointed out, most caregivers are women, are middle-aged women, and many women will find that they contemplate leaving the workforce to do caregiving. And I really, really, really highly encourage them to really think about it, because what has been found is doing that really sets a woman back for her own retirement. And then the question becomes, who's going to take care of her when she needs care? So we do want to keep that in mind. But really, anything a person can do for their own physical, emotional, psychological well-being is part of self-care. Next slide. Okay, so I'm going to do a quick run through. Hold on. Oh, okay. I want to do a quick run through just of our programs. You can do the next slide, because I think we pretty much covered a lot of this stuff. I know Dante covered some of these. We have a helpline. Our helpline is actually, you know what? You could do the next slide, because I have a slide for each thing. So our helpline is our gateway to all of our programs and services. With our helpline, a person can talk to a caring professional about concerns. They can ask for a referral. If the person, one major thing that I tell my clients anyway, is that when it comes to getting a diagnosis, it's really important to go to a specialist in cognitive impairment, because I have had clients, they have gone to the top neurologist only to find that the top neurologist was for back pain and not for cognitive impairment, and they ended up having a really awful experience. So if anybody needs any sort of referrals, they can come to us. If they want to do any of our programs, they can call this. They can, basically, this is the gateway. Next slide. We have support groups. 85 plus in all 5 boroughs, except that, with COVID now, it's pretty much all virtual. I think we're starting to have some that are in person. We have specialty groups. All of our support groups are based by are separated by relationships. So you'll have a spousal support group or an adult child support group, and within that we may have some other cultural specialties, such as LGBTQ. We have I think we have a Spanish speaking one. We have we have an Orthodox Jewish one. We have siblings. So and
Chinese.
Chinese. Oh, that's a good one. Thank you. Yes. So if and obviously, if any other kind of new issue comes up, it's interesting for us to know if there's a another need in terms of a type of support group, so that if that ever comes up, you can also feel free.
And we have also support groups specifically for certain types of dementia, because the trajectory is a little bit different. So we have specifically for Lewy body and for frontal temporal dementia. Sorry.
Oh, no, thank you. No problem. All of our group leaders are professionally trained and supervised. I should actually, Susanne, maybe we can also plug that if anybody here is interested in becoming a support group leader, we are always interested in recruiting and finding new support group leaders. We provide training and supervision ongoing. So you can talk to Susanne about that if you're interested. And the idea being these support groups are creating safe, welcoming environments to deal with issues of being a caregiver. It really gives them a feeling of not being alone. Okay, next slide. Okay, we have our education and training. Dante actually went through that. Next slide. Okay, Connect to Culture is a wonderful program of ours. This program partners with different cultural institutions throughout New York City to provide dementia-friendly programming. We use we do things with museums, we do things with the botanical gardens, we do things with different musical and dance groups and things like that. We're actually going to be having on Wednesday a concert at our office at 360 Lexington Avenue with people from the Orpheus Chamber Orchestra. And they're going to be doing an hour-long concert for people with dementia and their caregivers. So that's also something to know about. All of our Connect to Culture events are on our website, and you can register on the website. There's a calendar with links. Next slide. Okay, Wander Safety Program is also a very important program to know about. This is a 24-hour nationwide emergency response service. Our program is New York City specific. It is in partnership with MedicAlert. It provides a bracelet, that titanium bracelet. On the back, it says the person with cognitive impairment. It has a tracking number and it has the MedicAlert number. This way, if somebody were to wander, a person can, look at the back of the bracelet. They'll see what the story is. They can call MedicAlert, and they will be put into contact with the emergency contact really quickly. It has been shown to really reduce wandering time, which is really important because wandering is a life-threatening emergency, and about 2/3 of all people with dementia will wander. So if that is something of interest, definitely call our helpline. There is a fee. All of our programs are free of charge, except this one has a small service fee. We do have scholarships for the first year. So if that is certainly a very important resource to know about. We have bracelets for a person with dementia. We also have bracelets for the caregiver. I should also mention these bracelets are useful not just for a wandering incident, they're useful for if somebody were to, God forbid, fall on the sidewalk and be knocked unconscious. And then, even for somebody who is not impaired, it is helpful so that this way they're known to, that they are caring for someone. So these are all, important considerations. Next slide. And lastly, we have some resources for palliative care. We have a bunch of different newsletters and brochures and pamphlets around palliative care. And if that's something of interest, you are most certainly welcome to look on our website to see more. I think with that, next slide. I believe. Yeah, so in terms of referrals, I know that it's been in the chat, but if you are interested, our referral form is on our website, or you can call the helpline. Next slide. Okay, and now we're up for questions. I hope I have enough time.
Yes, thank you so much. So I know that there's probably some questions in the chat, but does anybody have any questions before we look at the chat? See, can I see the whole chat? I don't know. Let me see. Hold on.
Let me see. Have some good comments.
Yeah. Any questions that you can see, Adina?
I'm looking. I'm right now. I'm just
Okay.
reading.
All right. You can be my chat helper because it's difficult for me to see it when I have the PowerPoint up.
Hold on. Okay. Oh, somebody wants to know if anyone can attend our workshop, even if they don't know anybody with dementia. I'm pretty sure, yes, they're open to the community. Anybody interested in dementia? Are there programs providing recreation, spas, etc., for the caregiver?
Well,
yet.
you mentioned some of the respite programs that are available through Department of Health, Department of Aging. Right now we have, I think we have some grants, right?
We do have grants, yeah. For respite, yes. But in terms of recreation for the caregiver, what I would say, Connect to Culture does have some caregiver specific programs. So you can look that up online. I know they used to do ones with the Rubin Museum. I'm not sure if there's anything coming up, but they have done that. And I know that we've been talking about doing stuff, but so far you're going to have to stay tuned for that because we don't have anything.
Yes, I mean, we are definitely, it's one of our goals to be able to raise some funds to offer true respite programs for caregivers, for care partners, to be able to give them a couple of days away from the caregiving responsibilities, while at the same time knowing that somebody is caring for their person. So, but it's not something that we're currently doing, but it's something that we would definitely like to add to our services that we provide.
Are there specific cultural strategies that have worked to encourage caregivers to reach out and accept help?
I mean, I think that we are definitely, I wouldn't maybe use the word struggling, but I think we would very much like to expand our services into some of those marginalized communities that don't necessarily look for diagnoses or look for help because maybe it's not something that they're used to, and they are like, maybe there's some distrust in terms of like distrust in the medical community. So we are trying to expand our services and try to get embedded with and helping community organizations that are already working with those populations in order to become a more trusted partner to those people. And I know, Adina, you're doing it in the Orthodox Jewish community, and we're currently working to see if we can get Dante more connected with some of the community organizations in the Bronx, so we can go out and meet more people one-on-one to start creating some relationships.
Yeah, I would also say though, in terms of, I mean, I don't know if it's specific cultural strategies, but I've found that, you know, usually if they're calling us, there's somebody who's open to it. You know, it's not, you know, and trying to at least work with that person within their framework and within the consideration of the cultural considerations of the family. I think once people get two things, once people know that you get them or you want to get them, I think that's definitely helpful and definitely makes them more receptive. But also once they realize that you can actually provide them with something beneficial for them, I think is also really important. And so that I guess that's kind of what comes to mind for me. I'm wondering, Dante, do you have anything to add on that?
No, I don't.
Oh, sorry.
I was actually looking at the chat, and that was a good question about if there's nothing else about that, about outreach to the African American community. And just to put it out there, we are looking for social workers to add to our team, specifically to do outreach in the African American community and more with the Hispanic Latino community as well.
Mm-hmm. Let's see.
So if anybody is interested in those positions, they are posted on our website.
You mentioned stigma, but what about fear? Once somebody is diagnosed with Alzheimer's dementia, there's a lot of fear. For example, fear of losing their license, not being able to drive and have control of their life. That's very real. And I think, you know, some of it is kind of necessary, just thinking about the losing license piece, and I think it's also understandable. I mean, one thing I think that comes up when we're counseling caregivers, particularly around difficult behaviors, is the importance of being able to validate the emotional experience of what the person with dementia is going through. And you know, it's not, you know, it's I think that fear is very valid. And I think being able to validate that fear is important. And I think also being able to provide some degree of reassurance that they're being supported is important. It's not going to be the be all and end all. It's not going to be the panacea, but it's certainly is something. I think certainly much better to validate that fear than to pretend like it doesn't exist. And I will also put a plug in for the fact that we do have this is actually for tomorrow's presentation, but we do have a support, a psychoeducational support group for people who are in the early stages of dementia. So, you know, there is support out there for people. It is virtual, so I believe for now anyway. So,
Yes.
you know, it's accessible. So if that's another, I think, important component to find other people who are going through the same thing, can actually be kind of helpful for some of them.
How much time do we have? Do we have until 11:30 or 12?
Actually, we have until 12, but
Oh, we do.
12.
Oh, okay. I thought it was
Okay.
11:30 because
we need more questions. Any
Can you stop
questions?
sharing so we can see faces?
Yeah.
Yes.
I
can
love seeing
stop you.
faces.
Yeah. Let's see each other.
So
While
just to-
we're waiting for some more questions, I wanted to just stress that we do have our services mostly in English, of course, in Spanish. Adina has connections in the Orthodox Jewish community, and then we have our services in Chinese and now also in Korean. And we have them in both of the Chinese languages, Mandarin and
Cantonese.
Cantonese.
yes, Cantonese. Yes, exactly. Thank you.
Hi, I'm Elaine Subin. I'm at the Center on Aging at New York Presbyterian. Hi, Adina.
Hi.
Thank you. You've presented to our faculty in the past, and I just wanted to say thank you to all of you and people that work in your organization. We regularly refer our patients to your dementia care specialists and helpline. And I wondered if you could talk a little about, once I make that referral to ask for a dementia care specialist, what are the next steps? What happens?
So Dante and Adina, does one of you wanna, because usually it ends up with one of you. So
Yeah.
the helpline.
So for me, for example, when someone calls the helpline, and I've answered calls on the helpline as well, we receive someone who wants to have a consultation, a one-to-one consultation. So that if at that time the person who's calling, either Adina or myself answer that call and they're available, we'll just go straight into the consultation.
Mm-hmm.
Now, if we don't answer the call, then that gets filtered to us. And then we will contact the person and schedule a time, either in person. Some people are actually preferring to come in person as well to our office, but you know, Zoom as well, if someone's like in the Bronx or Brooklyn, or over the phone. And so sometimes we also have people who don't have that technology for Zoom and don't want to, or are unable to come in, so over the phone. And we would have that conversation. We would try to find out what their needs are, what are they calling, like, because it could be a broad range, whether it's just this one-to-one, only one time, or ongoing, or refer to one of the programs that we have, or if we don't offer it, they want to, we know something that it can help, we refer them to the community. And I follow up to see what's going on a few weeks later as well. So I think that's very important, not only to have that initial conversation, but also a follow-up to see what happened. Maybe they didn't do anything. And so kind of encourage them to continue to look for help on their needs. So it really depends on their needs. We receive a lot of calls, so sometimes we don't. I personally sometimes it's hard to, okay, so let's say you refer someone and then we contact the person. We are unable to contact that person. We try, we give 3 attempts, and then after that we let you know, hey, we tried to contact this person and we were unable. Or you could reach out and say, hey, by the way, I referred somebody, or can you tell me a little bit about what happened? So we have all that documented. So let's say I spoke to someone, I'm not available, I'm not around, but my notes are. And Adina could say, okay, well, yes. Or someone at the helpline could say, yes, well, we try to contact them 5 times and they haven't, well, we've been playing phone tag. Or yes, we did. They are participating in this, and that. And that, so that's different scenarios of what can happen.
Right. And we will talk a little bit about this tomorrow, but if the referral is made for somebody living with a dementia, is referred to our early stage, one of our early stage services. We have an early stage specialist who will do an assessment of the referral of the person to make sure that they are appropriate for the early stage services, whether it be the early stage support group or the early stage cognitive stimulation therapy, because we want to set people up for success. We don't want to plug them into a group where they're going to feel that they're not a good fit and they're going to feel embarrassed or that they can't participate, or so we want to make sure that they are actually appropriate for the programs that we recommend for them.
Yes. So I just spoke to someone before we got on this call, and it was the person who I used as a quote, who really is interested in the coaching program, for example. After I spoke to her, it may not be the first thing on her plate. So I'm looking for some resources to follow up and give those resources, and then kind of circle around again in a few weeks and say, okay, well, how is this going? And we can go over some of the challenges and see if this would be something appropriate. Because ideally, it's not for everybody, but at least to have a sense from us, dementia specialists, to see what can we suggest.
Yeah, and I would also say that, just because the person's not ready for something at one point, usually once they've contacted us, they're kind of still within our clutches. So they do eventually get what they need. And I mean, one thing we really strive to try to be there for throughout the course of the illness. So, a person may contact us in the early stage and get what they need, may not contact us for a while, then middle has different needs, and then at end stage as well. So we're really there for them at all stages, as needed, I would say.
Thank you so much.
I'm going back to the chat a little bit, and I see that somebody asked if we offer family therapy. I think specifically for Latino families or families of color. I think we do have something called a family caregiver workshop, but we don't offer therapy or counseling per se. I mean, we do more like psychoeducational workshops, and we can certainly work with families. Adina?
Well, I was going to say, I mean, we don't do family therapy like an ongoing thing. I have done family consultation, where I'll have several family members, but it's usually maybe 1 or 2 sessions or as needed, but it's not like an ongoing kind of.
Right. I also have been trained in the NYUCI, which is the New York University counseling intervention, which is focused on families. And I've had a few clients who were interested in having, like Adina said, just have a Zoom, for example. And sometimes families are in other states. So we have a conversation with family and talk. It's not like therapy. It's definitely not therapy, but it's just a consultation with their families. And even if the person with dementia also feels comfortable, depends on the family, but it's usually the caregiver. And for example, I've had consultations with spouse and her children to talk about that. And it's not like a one-time consultation, because then I usually do follow-ups, and then, okay, well, let's meet again in a month to see what has happened and what has changed. And if needed, we're also available ongoing. So it could definitely be just a one consultation or ongoing, depends on them, but we're here for them.
Yeah, I also want to add, I mean, one positive thing that came out of the pandemic is that we're very virtually connected. We actually, we're no longer, at least in terms of individual clients, bound to just New York City. So if people do have people from out of New York City, out of state, we do provide assistance as well.
Yeah. Yes. I actually have one of the group with Partnering Together. One of the participants, she lives in Nevada. I also do what you'll hear about cognitive stimulation tomorrow. I run those in Spanish, and I was gonna enroll someone who from Puerto Rico. So it depends on where they're at, and if they would like to benefit from this, they're more than welcome.
And if they don't mind any time zone issues.
And then I see one question from Janina. Does your organization offer internship fellowship opportunities for social work students? Yes, the answer is yes. We would love to have a social work intern that is currently enrolled in a master's program somewhere. We all licensed social workers and are able to do that. And I think Adina has a CIFI already. So yes, if you have anybody good that you want to send our way, we would be very, very happy to take them under our wings and give them a good experience.
How about a BSW student?
Why
not?
I guess we could.
Yeah.
Yeah, I guess we could. I think we have the credentials for it. Yeah.
I've never done a BSW student, but I don't see why not.
Yeah. We just want to make sure that we can provide a valuable learning experience for whomever we decide to take. Yeah.
I'd say we just want somebody passionate about this population.
Yes. Yes. Any other questions? So I don't know if anybody is signed up for tomorrow's session. Tomorrow we are going to focus more on the actual person who is living with a dementia. And so the intro is going to be a little bit of a repeat of the intro for today. So but then after that, we're going to jump into the services and supports and programs that we offer to the people that are actually living through the experience of having a diagnosis. Any other questions? I think Angelique shared with us that, oh, she just put it in the chat. Okay, all right. All right. Well, we're really happy that everybody joined us today. We're if any follow-up questions, please feel free to reach out to one of us. I think Angelique will be sharing the PowerPoint with our contact information, our email addresses, and the helpline number, and also the referral form. And
just to finish, also, Susanne, the helpline is not only for families. So if you, as social workers, feel you need any type of guidance or just like a second thought on a challenging case, you can also feel free to give us a call and say, two brains work better than one. But yeah, so that's, we welcome your calls as well.
And if you're working in settings where you feel that it would be valuable for one of us to come and share information about CaringKind or share information about one of our programs, we're also happy to do that. We love to get out and to talk about the services that we offer, and we really want to reach as many people as we can. And remember that, our services are free. So. No, this specific course does not currently offer CEUs, but we do have others that we are working on that we do. We are accredited, so we can do that.
Excellent. Thank you all for coming today. Let me move the